All right, guys, let's talk about shock here. Out of all the subjects that we teach EMTs, I have always found that the EMTs find this subject to be one of the more complicated ones to grasp and understand. And there's a lot to it, but just to understand that shock is comprised of three things: your pump, your fluid, and the container. So just remember those three things when dealing with shock. One of those three things is going to be messed up. You should be okay. But moving forward here, shock. We absolutely must know this definition. You will have to know this definition for the rest of your career if you're going to be a paramedic, if you're going to be a flight paramedic. They ask you this all the time. Okay, shock is defined as inadequate cellular perfusion, inadequate tissue perfusion, inadequate metabolic needs are met. Basically, the oxygen in blood is not getting to the cellular needs. That's shock. Okay? We need to be able to identify this as EMTs. There's not much we can do about it, but we absolutely must be able to identify it. And not only identify when we see shock, but we must be able to differentiate what type of shock we're dealing with. Okay? The last line, it says in early stages, the body attempts to maintain homeostasis. That's just a fancy word for saying that after somebody gets stabbed, shanked, cut in a car accident, anytime they have type of injury, a lot of people think that the blood pressure is automatically going to spike and the pulse is automatically going to go low, and all those tend to be very late signs. When our body is in the first part of shock, it does a really good job of making our vital signs relatively normal. So just know that we must be able to recognize the early stages of shock so we can prevent it from happening any further. Okay, pathophysiology. Let's talk about this word diffusion. I'm sure you guys have heard this word. I know we've talked about it a lot in class, but diffusion. It is so important that we understand that this is how the oxygen and the carbon dioxide move in and out of the alveoli. Okay, just know that diffusion is the movement of molecules from the area of high concentration to low concentration. Okay, so when we take a deep breath in, we have a whole bunch of fresh oxygen going into our lungs. When that whole bunch of fresh oxygen gets to our lungs, it meets up with a whole bunch of carbon dioxide that needs to get offset. Well, the carbon dioxide knows that there's not a lot of carbon dioxide where there's a lot of oxygen, and the oxygen knows that there's not a lot of oxygen where the carbon dioxide is, so they swap spots. That's diffusion. This is the whole purpose of what keeps us alive, is diffusion. Like if we don't diffuse, we die. So diffusion is just a crazy important concept that we understand and know what it means. And it just basically means that oxygen in blood is being able to be transmitted through the alveoli and be able to release your oxygen into the blood, take the carbon dioxide out, and blow it out. Okay. Once again, shock, it's not good. Okay. It builds up waste products. We should be able to breathe out all of our carbon dioxide, but if we can't, that carbon dioxide is just going to be able to increase and increase and increase. And as that builds up, that acid, it causes a lot of cellular damage. No good. Very bad. We do not want that. Here's just a little picture showing us the pretty much all three things that we need to deal with here. We got our pump, which is right in front of you. It's the heart. Okay. Blood is everything that is carried around in the heart and veins and arteries. And then our container is our arteries and veins. So those are our three things. Goes into the right atrium, right ventricle. That's deoxygenated blood. Goes over to the lungs where it gets oxygenated. After it gets oxygenated, it goes over to the left atrium, left ventricle for systemic circulation. That oxygenated blood is going to go down to systemic circulation, and that's where the oxygen and carbon dioxide are going to exchange places. And the whole process just repeats itself endlessly. Once again, this just kind of recertifies. This is like the third time we've seen this slide, guys. So you must understand that shock is very bad. It leads to death, and we have to be able to identify it. Okay, here are the three things that consist of the cardiovascular system. We got our pump, which is our heart, the container, which is our blood vessels and arteries, and then we got the blood. Those three things make up our cardiovascular circulatory system. All three of these things have to coexist with each other. If there's a problem with one, the other two are going to show signs and symptoms. So just know that all three have to be perfect, or else two of the other three are going to show some kind of differences. Okay? Our pump should be able to beat between 60 and 100 beats a minute. That's our normal pulse rate. Our blood vessels should be able to constrict and dilate as our body needs it. And then our blood should go around and around and not have any clots in it. It should be nice and clean. And it should be able to diffuse oxygen and carbon dioxide. Okay. Blood pressure and pulse pressure. These are two definitions that we absolutely must know. Of course, we know what blood pressure is. That's the amount of blood, the amount of pressure during the systolic is the amount of pressure that is being exerted over the vessels when the heart beats. Diastolic is the amount of pressure in your vessels when your heart is chilling, when it's just relaxing, when it's not beating. So that top part is your top number is your systolic, and your bottom number is your diastolic. So a normal blood pressure is 120 over 80. Now, if you go down to pulse pressure, that's the difference between the systolic and the diastolic. So in that blood pressure that I just said, 120 over 80, 120 minus 80 is 40. So that tells me the pulse pressure is 40. Here's another example. If my blood pressure is 140 over 100, again, my pulse pressure would be 40. My blood pressure is 130 over 110. Then my pulse pressure is only 20 because I have a 130 systolic and a 110 diastolic. So that would be just 20 for my pulse pressure. Typically speaking, we want to see pulse pressures. You want to see about a 25-point gap between your systolic and your diastolic pressure. If you start having pulse pressures that are narrow, less than 25 millimeters of mercury, such as like a 110 over 100, 100 over 90, 120 over 110, any of those, that's a bad sign that that patient might be going into shock. We need to find out what's going on. Okay, sphincters. Sphincters are our one-way valves. These things make sure that our blood flow goes in one direction, and it helps constrict, dilate our blood vessels, determined by what we need. So just know we got sphincters. It kind of helps the blood go one way. You see those little round little things? I doubt that's what they look like in real life, but you understand what they're saying. Their whole job is to be able to sit there and constrict or dilate as the body needs it. So those blood vessels can either get bigger or get smaller. So when our body goes into shock, our body does a lot of things. It releases hormones. It releases a hormone called epinephrine or adrenaline. Okay? That adrenaline, which is the same thing we give in epinephrine, is going to increase the heart rate. It's going to make the heart rate beat even stronger. And it's going to cause those blood vessels to constrict. That's what happens when our body starts going into shock. That is our fight and flight syndrome, and that's basically our sympathetic nervous system kicking in and increasing our heart rate, increasing the strength of the contractions, and then having vasoconstriction to our vessels. Anytime somebody has a shock, their body's going to try to respond in this way. Here we go, causes of shock. 3 different things, like I said. It's either going to be a pump problem, a low fluid problem, or a poor vessel function. So either your heart's going to be crappy and it's not going to beat very good, or it's going to be obstructed. It won't be able to beat effectively because something's blocking it. You could have low blood volume because you cheated on your girlfriend and she cut you, and now you are leaking out all your blood, and so you're about ready to die because you bled out. Or you could have low blood volume just by simply, this is very common in kids and pediatrics, if they vomit and have too much diarrhea and they don't replace that fluid. Kids, especially infants, are notorious for this. They go on a 2 or 3 day bender of just having really bad diarrhea and vomiting, and they're not wanting to take in fluids. These guys will get low blood volume very quickly. We need to pay attention to that. We'll talk about that when we get to peds. And then our poor vessel function. Remember, our vessels are our veins and arteries. Our veins and arteries should be able to constrict, that means get tinier, or dilate, that means get wider, whenever our body needs it. Some things that could cause the blood vessels to dilate uncontrollably: drugs, allergic reaction, spinal cord injury, massive infection to the whole body. These are just a couple things or a few things that can cause those vessels to not work very good. Remember, we want our vessels to be able to constrict and dilate at a moment's notice, at our body needs. And if we have some sort of shock, we lose that ability for those vessels to constrict and dilate effectively. Okay, here we go. We're going to start going to some more of the names of shock. Now we got causes of shock. We had types of shock. You got your pump, your vessels, and your fluid. Okay, but when we get to pump failure, we got cardiogenic shock. Cardiogenic shock is just simply the heart doesn't beat effectively. Most common cause of that is a heart attack, aka myocardial infarction. It's just a fancy word for heart attack, myocardial infarction. So heart attack doesn't allow that heart to beat effectively. So that's one of the number one causes of cardiogenic shock is a MI, a heart attack. Now let's say that heart is fine. It's not having a heart attack. But let's say there's some sort of obstruction in the way. Well, that still falls under cardiogenic shock, but it's cardiogenic because there's something obstructing the heart. 3 things that could be is a tension pneumothorax. That's where the air compresses down on the heart and doesn't let it beat effectively. Cardiac tamponade, and that's where fluid encircles the pericardial sac and literally tamponades and compresses the heart so it can't beat effectively. And then you got your pulmonary embolism, which is just a blood clot in your lungs. And those 3 things, the heart is fine. It's not having a heart attack. It's just the heart is finding some sort of obstruction that is trying to pump against, and it's failing. We're going to go into more of this in a little bit. Poor vessel function. I would say this is probably the one that we will see a lot as EMTs because there's 4 different types of this. And just know that poor vessel function is called distributive shock. And that just means that fluid, it stays in you, it just doesn't go in the vessels anymore. So rather than being in the vessels, it seeps up into our interstitial fluids, and our body's not able to compensate for that. So poor vessel function is a type of distributive shock. Things that cause that is a septic shock. That's when we get a really bad infection. Neurogenic shock, when we have like a spinal cord injury and the nerve pulses aren't being sent down to our spine and our peripheral nervous system, so our body's not able to do the vasoconstriction or the dilation as it's needed. Anaphylactics is when we have a massive allergic reaction, and because of that massive allergic reaction, our body releases a bunch of antihistamines, which causes our body to have a lot of dilated vessels. So people with anaphylaxis, that's a severe allergic reaction, they tend to have fast heart rates with low blood pressure. We need to pay attention to that. And then psychogenic shock is just kind of like that. You get bad news, you learn your girlfriend cheated on you or your man cheated on you, whatever it is that you are rolling with, and it really upsets you, and you have that brief moments of syncope or fainting. Basically psychogenic shock. Psychogenic shock will relieve itself. There's no real long-term or mortal concerns to be down there with. Every now and then you might find somebody that would have this because they have like a brain aneurysm, but 99% of the psychogenic shocks is just people being overly aroused and having a brief moment of syncope, a brief fainting episode. And then we got our last one, and this is our blood one, this is our volume one, and that's when we lose our volume. Like I said, it could be as simple as bleeding out because you get shot or stabbed, severed an artery. Or the non-hemorrhagic shock is for those kiddos that I was talking about earlier, where they poop out, vomit out, and don't take in enough fluids, and over 2 or 3 days, they lose a lot of their blood volume, a lot of their fluids, a lot of their volume in their body, and they become called a non-hemorrhagic hypovolemic shock. So basically saying they're not bleeding out, but they don't have enough volume to sustain life. These kids will look really crappy, but the good thing is once you give them an IV for paramedics, when you see this, you give a dehydrated kid that's been vomiting for 2 or 3 days, you give them a fluid, a liter of fluid, and they will be a new kid in a matter of an hour. All right, let's really deep dive into this cardiogenic shock. So as I talked about, this picture right here is showing you that little blood clot right there in that left anterior descending coronary artery. So you see a little yellow thing right there that's enlarged. That's showing you that there's a blood clot right there. No blood is getting past that anymore in that heart. So that heart is going to start to die. When that heart does not beat effectively, a couple things happen. We have shortness of breath. Our lungs might start to back up, and that's where we get the pulmonary edema. That's where we get the fluid in our lungs. And when we listen to that lung sound, you hear the crackles and the rows, and it'll basically sound, it sounds just like fluid is in the lungs, because literally there is fluid in the lungs. So when you listen to it, it sounds like wet Rice Krispie treats, and you can hear it, especially when they take a deep breath out. It's more pronounced in the bases and the lower part of our lungs than the upper, but this is one of those lung sounds that we absolutely must be able to identify, know what it is, and know what's causing it. Okay, if the blood vessel does not, or the blood doesn't accumulate in the lungs, it will accumulate in the legs. So these are people, when we look at them and they have the really swollen ankles habitually, like a very long time, like multiple days, their ankles are always swollen. Typically those people have some form of CHF, and if they have CHF, congestive heart failure, cardiogenic shock, if they get sick, cardiogenic shock's not going to be too far behind, because CHF, they're already got one leg in the grave because their heart's not beating effectively. So if they get a heart attack, they're going to go into cardiogenic shock rather quickly. So once again, just pay attention to lung sounds. Lung sounds should be clear, but with cardiogenic shock, you're going to hear the crackles and the rows. You're going to notice pedal edema, so that means swelling to the lower extremities in the feet. So we're talking about the heart not being able to beat effectively. So when we talked about that, it's how hard the heart can beat, how hard it can contract and push that blood around. Okay, that's number one. Number two is the amount of blood to pump, the preload. What's preload? Well, preload is the amount of blood that is in our right atrium and our supra and inferior vena cava when our right atrium wants to receive blood. Okay? If our blood vessels are very, very dilated because we are having an allergic reaction, because we got shot and severed our spinal cord, and our spinal cord can no longer constrict, our preload is going to be very, very low because our blood vessels are so dilated. So that's going to hurt our ability to pump effectively. So number two is the amount of blood to pump. That's preload. That's in our right atrium, our inferior and superior vena cava. All that blood that's returning from the body to our heart, that's our preload. And then our afterload is how much or how hard our left ventricle has to push in order to push out all the blood to the body. So how much vascular resistance there is. So imagine if you have blood vessels that are very constricted and that ventricle is trying to push out, it's going to meet a lot of resistance. And that a lot of resistance is going to cause the pressure not be as great. So pay attention to stuff like that. Okay, obstructive. We talked about the last one where the heart was beating effectively or was not beating effectively. This is where the heart is fine, but the heart's beating the heart's not having a heart attack, put it that way. So there's nothing wrong with the heart itself, but the problem is something is making it hard for the heart to beat. So cardiac tamponade, that's where the fluid accumulates around the pericardial sac. Tension pneumothorax, where air gets into the pleural cavity and puts pressure on the lungs, and as that pressure increases, it shifts over and starts putting pressure on the heart. So if you have pressure on the heart, just like with a cardiac tamponade, the heart's not going to be able to beat effectively. And then a pulmonary embolism is a blood clot in the lungs. So when your heart is trying to beat and perfuse the lungs and the body, there's a massive block with an embolism somewhere in the lungs that's causing some obstruction. And that's going to cause what we call a ventilation perfusion mismatch. If it's big, if it's bad, it can definitely lead to a shock, and that shock would be obstructive in nature. Okay, here's the cardiac tamponade. Here's a picture of it. So if you look to your right there, you see the picture of the heart, and then it has the pericardium, and you see how big of a sac that is. Well, that sac should not be that big. That sac should be just lying right over the heart as like a protective little shield over it. It should just have nothing in between that and the heart. The pericardial sac should just have some fluid that helps it move back and forth. But right here we have a massive amount of fluid buildup. So it could be of blood, it could be of infection, it could be of anything. But any time where that fluid builds up in the pericardial sac, it's going to compress the heart and not allow it to beat effectively. So this is called a cardiac tamponade. Imagine somebody gets hit in the chest with a baseball bat or baseball, and it bruises the pericardial sac. Well, as that sac gets more and more inflamed, maybe it starts to bleed. Well, that blood is going to accumulate in the sac, and it's just not going to let, as it continues to grow, it's going to not allow the heart to beat effectively. And then it's going to have signs and symptoms referred to as Beck's triad. Beck's triad is one of those things that as EMTs, 1000% have to have this stuff memorized. We have to be able to know what it is, because they will ask you questions about this. They want the EMTs to be able to identify and know what Beck's triad is and what it means and why the patient has it. So the Beck's triads are, we call 3Ds. Okay, distended neck veins, distended jugular veins, JVD, jugular vein distension. Those are those veins that sit on the side of your trachea, and they tend to get very enlarged with like kids when they get really pissed off or angry. Sometimes adults, when they rage, you'll see those veins pop out. Those are called your jugular veins. Now, 99% of the time, if you look around anybody in your class right now or your teacher, you probably cannot see the jugular veins. They just are hidden, they're compressed, they're not distended, so you don't see them. But when somebody's talking to you and you see them and they're just sitting there and you can see their neck veins, you're like, that's kind of odd. I don't remember seeing that before. That's JVD. We have to pay attention to that. And we also got decreased atrial pressure, which is just a fancy word for hypotension. And then diminished heart sounds, so muffled heart tones. I know that we don't listen to a lot of heart tones as EMTs, but when you listen to a heart, we should be able to hear that boom, 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 boom. Now, if that gets muffled and it sounds like you're under a bunch of pillows, that right there is muffled heart sounds. These three things, distended neck veins, muffled heart tones, and hypotension, are your Beck's triad. You absolutely must be able to identify this and know it. An example is they're going to tell you that like a 18-year-old football player took a hit to the chest 2 days ago. He's been complaining of chest pain. As you assess him, you notice that he's having shortness of breath. He's got distended neck veins. His heart rate's 120. His blood pressure is 110 over 100, and they have muffled heart tones. Well, we have to be able to identify as EMTs that those three things make up Beck's triad, and this patient probably has a cardiac tamponade. Now, there's nothing an EMT can do about this. We must transport them quickly. Old school paramedics used to do a thing called pericardiocentesis, where we could take a needle and actually go into the chest and drain that fluid. But they discovered that a lot of paramedics were messing that up, and so we no longer do that as paramedics. Here's your tension pneumothorax. So if you look over to this picture to your, I guess it's your right, you see the normal lung on the right-hand side with the pleural space. That lung is fully inflated. It says normal lung, and then it's got the pleural space. You see, like I said before, that pleural sac around any of our organs should be nice and firm, almost like it's got a protective sealing over it. And on the right, that's exactly what it is. The normal lung is covered by the pleural space, and it's basically just like a little like bodyguard to make sure nothing messes up with the organ. It's just like a little protective layer. But if you look to the one on the left, we see all that blue. That's where air has gotten into the pleural space, and now it's inside that pleural space, and it's got nowhere else to go except for accumulate inside that pleural space like it's a balloon. And as it accumulates in that pleural space, it's going to compress that lung. So you see why it says collapsed lung? That's because all the air is in that pleural space. And as we take a deep breath in, that pleural space just gets bigger, and the collapsed lung gets even smaller. And each breath, it gets worse and worse and worse and worse and worse and worse and worse. And eventually, that collapsed lung is going to shrink all the way down, and that air in the pleural space is going to become so intense that it's actually going to start to shift over and start to put pressure on the heart. And so that's when it gets called a tension pneumothorax. So imagine this lung right there. You see where it says pneumothorax. Imagine that lung being completely empty or completely small as can be. The blue being as big as it can be. And now it's so big that it's actually pushing over towards the healthy lung. Well, it compresses the heart. So that caused tension pneumothorax. That causes obstructive shock. The heart can't beat effectively because of that obstruction. You also hear things called tracheal deviation. This is a very late sign, but that trachea, instead of being straight up and down, will actually start to shift over towards the healthy lung, so it can get better air. And because of so much pressure is being exerted, it goes over towards the healthy lung. So I know that when we do a DCAT BTLS or a rapid trauma assessment of a patient, when we look at the neck, we look for JVD, we look for tracheal deviation, and we look for cervical step off. These are one of the things we're looking for. We want to see if they have tracheal deviation. Typically, tracheal deviation is a very long, delayed symptom. We usually don't see it in the pre-hospital setting, but that's not saying that we won't see it. It's just saying it's typically a late sign, so don't expect to find this. Just make sure that you're looking for it. Here's that pulmonary embolism, and as you can see right here, homeboy right here has just got, you see a little arrow, the white arrow goes up, got that little clot goes up into the right atrium, followed a little white arrow goes through the heart, and then it gets into the lung. And you see right where that white arrow ends, you get that little clot in the lung. That clot in the lung is called an embolism, and because it's in the lung, it's called a pulmonary embolism. Pulmonary embolisms, very common, especially in people who have, well, I won't say very common, but in test questions, they're very common in patients who just had surgery, or they live like a sedentary lifestyle, like truck drivers, people that are on their butts a lot and don't get up and walk around. Okay, a clot can form in the lower legs. That's why if you see, look over that picture with the full body, they got that little redness down in the calf. That's showing you that a clot formed down in that calf, and when moved up into the heart, it went up into the heart, and then it gets into the lung, finds a small spot, and then it clogs it. When that clot happens, that's a pulmonary embolism. That's another one of those ventilation perfusion mismatch issues that we hate, we need to fix, but we can't fix this as EMTs, but we have to be able to identify this. These patients generally have shortness of breath. It gets worse when they take a breath. Lung sounds for these people, believe it or not, you might not, probably not going to hear it. You don't hear a pulmonary embolism. You might hear less ventilation, but remember, you're not having a trouble getting the air in and out. You're having trouble getting blood to the alveoli because the alveoli is blocked. Okay, now we're going to move past cardiogenic shock. And now we're going to talk about distributive shock. This is nothing more than your blood vessels dilating. All that blood going out of the blood vessels and getting into the interstitial fluids where it's not being able to be diffused. It expands, it gets out there. We don't really want that. So if you look up here to your left, you see the tube on the left looks like a normal tube. The one on the right where it says vasodilation, all it is those blood vessels have gone really, really wide. Vasodilation. Vasodilation. It's not a bad thing unless we don't want it to happen. Our body goes into vasodilation to vasoconstriction all day long. It's constantly going from dilating to constricting. But when it goes to dilate it and it stays dilated, that's not good, okay? We don't want that. So distributive shock. This is remember, this is where the blood vessels dilate and fluid doesn't stay inside the vessels very well. Well, one of the most common ones that we are going to see as EMTs is septic shock. I can't begin to tell you guys enough how underdiagnosed and underutilized we are with septic shock, especially in the EMT communities. The paramedics in the past 5 years have really started going towards being able to identify septic shock. But we as EMTs definitely need to be on alert for it because a lot of these patients that we pick up in nursing homes are at high risk of this type of shock. And basically septic shock is just like an infection that gets into the blood vessels and travels throughout the whole body. And because that blood vessels are infected and it's throughout the whole body, number one, all the vessels dilate. And then the vessels, they're unable to, the cells kind of leak. And this is where they say the fluid gets into the interstitial fluids. And this is where it's called third spacing. And this is where that fluid goes out of the vessels and actually just kind of goes into the interstitial fluids. And it's not being able to be perfused. It's not being able to be diffused. So it's bad. It's not something we want. Okay? Septic shock patients have, to me, a certain type of odor because they're sick. So typically I found these patients tend to be like a low-grade fever, 99 to 100. They tend to be pale, warm, and clammy. Remember, they're warm. They're not cool. They're warm. They have a low-grade fever. And they tend, like I said, they tend to have a little musky smell about them. Septic shock is something that you guys, like I said, will see a lot of in and out of nursing homes, taking patients to and from nursing homes as EMTs. We'll see a lot of this. And then neurogenic shock. Neurogenic shock is when our blood vessels can't work anymore. They can't constrict or dilate because there was an injury to the spinal cord. So back to you cheating on your girl or a girl cheating on her man and they get mad and they cut you in the back and they sever your spinal cord. Well, wherever your spinal cord is cut, from that area down, your central nervous system, your nervous system can no longer send or receive signals. So those blood vessels are just going to go ahead and dilate and stay dilated. They're never going to really ever vasoconstrict again because they'll never get a message from the brain saying to vasoconstrict because that spinal cord has been severed. Okay? When we look for priapisms with trauma patients, this would be a sign of a spinal cord injury. If somebody can't move their lower extremities and they have an active priapism, it's a really good indicator that their blood vessels are dilating. They're dilating because of a spinal cord injury, and that would be neurogenic shock. And then this homeboy right here, anaphylaxis. Now, all three of these, just to review, so septic shock, blood vessels dilate, they leak. Neurogenic shock, blood vessels dilate, they'll never reconstrict. And then anaphylactic, the blood vessels dilate and they leak again. This is because of an allergic reaction that is so big and so bad that it goes throughout the whole body. Remember, we don't care about allergic reaction. Those are no big deals. People have allergic reactions every day, all day. You gotta live with that. It's when it gets to the anaphylaxis where it becomes life-threatening. If you guys look at that little kiddo right there with the blown up lips, it's called angioedema. If those lips are swollen, that trachea and that airway cannot be too far behind. So imagine that airway being as swollen as those lips are. You're not going to be able to get any airway down there. Fortunately, and this is where it gets scary for paramedics, but if we can't get that airway and that airway closes, we might have to cut that neck in order to get air in there. And nobody wants to do that on anybody, especially a kid. Just know with allergic reaction, well, the first time we're exposed to an allergen, we might not or we won't have an allergic reaction to that. But each time we are exposed to that reaction and we've discovered that we have a response to it, each time is going to get worse and worse and worse. So let's say you're allergic to a cat. First time you're around a cat, probably will just bother you a little bit, but you're not going to necessarily see any signs and symptoms. You might get a little itchy, you might get a little irritated, but then the second time you see a cat, you're immediately going to start itching and start breaking out in the sweats and get itchy and blood pressure might drop. And every single time after that you're exposed to that allergen, it's just going to get worse and worse and worse and worse. Okay? When we go over allergies, we're going to go into a lot more with allergies and anaphylaxis and how it works and being able to really go a deep dive into that. But just know for shock purposes, with this, it causes our blood vessels to dilate. So these people will have low blood pressure. That's why EpiPens are so beneficial for these patients. The EpiPen goes into the muscles, and that epinephrine causes our body to have massive vasoconstriction. That saves lives. So EpiPens reverse the vasodilation, cause vasoconstriction, causes our heart to beat effectively, and it also causes our lungs to open up. So Epi is just like a win-win situation with those anaphylactic shocks. We don't give Epi with allergic reactions. That's just too gangster, too much. Okay. To review, distributive shock. This is or anaphylactic shock is another one of those terms for distributive. The blood vessels are dilating. So people who have anaphylaxis, they're gonna have all these, or some of these, or most of these, or maybe most, maybe none. We got to be able to determine which one of these signs and symptoms are carried. We care about which ones are the worst. Like if you look at this. To your right, stridor, horrible. We do not want to see stridor. We do not want to see secretions coming out of the oral airway. That means they can't swallow because their glottis is so swollen. We don't want to see that. That's a very, very bad sign. But just like if somebody just has plain up hives, no big deal. But when they have hives along with angioedema, along with cyanosis, along with a low blood pressure, along with secretions that are not being able to be swallowed, and they start getting mental status changes, that's when we start getting anaphylaxis, and that's when those guys, we must be very cognizant and very proactive with our EpiPens. And then psychogenic shock, this is just where I said it's temporary. It's typically a syncope, can be caused by fear. Like if you get, I don't know, let's say you're, I don't know, you get scared and you faint. That's psychogenic shock. Typically, not a big deal. They wake right back up. For all you boys that want to be dads one day, when you guys go to the delivery room, there are some dads that might faint when they watch the baby come out because it is bloody. So that's just psychogenic shock. It's just a syncope, really nothing going on there. They wake usually right back up. Out of all of them, this is the one I care least about. Okay, we covered cardiogenic shock, obstructive shock, and distributive shocks. Now we're into our last brand, if you will, This is probably one of the easier ones to understand. Hypovolemic shock. Now notice it says hypovolemic. It doesn't say hypo blood. It says hypovolemic. So that's our volume. Low volume. Our volume can be blood. That's going to be pretty obvious if somebody has a massive bleed. But we can also become hypovolemic shock if we have severe thermal burn. So if we burn off a bunch of our skin, our fluid's going to go into third spacing, and that's going to cause a lot of hypovolemia. You wouldn't necessarily expect that as EMTs, but we have to understand that if somebody gets really burned, they are at high risk for hypovolemic shock. For you guys that want to be paramedics, you guys will learn all about this thing called the Parkland burn scale, or the Parkland formula, and it's basically how much fluid we give after somebody was burned. And you will be amazed at the amount of fluid that we are going to give people when they are burned. It will blow your mind. So just know as EMTs, these people are going to get IVs and a lot of fluid if they have a lot of burns, okay? Another thing is probably the more common one we're going to see is those kiddos or adults that have too much vomiting or too much diarrhea and they don't replace it. That's why Pedialyte is so important with kids, because that Pedialyte will restore the volume but also replace the electrolytes. A lot of adults who are hungover will do the same thing. They vomited too much, maybe they had too much diarrhea and they feel very, very bad, probably because they got a lot of low blood volume. Being able to put yourself, being able to drink some good Pedialyte or electrolytes is going to help you out tremendously. Okay, so you get the progressions of shock. Now, ones I talked about earlier were the types of shock. Now, this is how shock progresses. Doesn't matter what type it is. You have pretty much 3 different ones, but we're going to talk about 2 right here. Compensated. That means our body is able to compensate. It's able to maintain our blood pressure. It's able to maintain a heart rate. It's able to maintain oxygenation. It's able to fight a good fight. That's compensated shock. That's when our body is fighting and doing everything it can to fight off whatever's causing us to go into shock. And then decompensated shock is when that body is like, you know what, dudes, I don't know if I can do this. So I might be piecing out here and you might die. And so that's not good. That's decompensated shock. That's a late sign. So some of these late signs is a blood pressure is actually one of the last things that falls. And once that blood pressure starts to fall, that patient's going to die pretty quickly. So we must know that during shock, blood pressure is probably one of the least valid indicators of how well or poorly that person is doing. What we want to know is, are they starting to go decompensated? So is their blood pressure going from 110 over 90 to 100 over 80 to 90 over 70 to 80 over 60 to 70 over nothing? That right there is decompensated. That's not good. Our body typically depends, they say about an hour. I guess it depends what kind of injury you have, but you have about an hour. Now there's one more after this, after decompensated shock, and that's just called irreversible shock. Those homeboys are dead. So once it becomes irreversible, they're dead. So it's just not good. So basically, majority of the time, our patients are going to be in that blue. They're going to be in that compensated shock. If they are in the decompensated shock stages with you, you guys get ready to start doing some CPR. Get ready to really start doing some EMT stuff, because those people finna die. Okay, this guy looks pretty mad, and you should know this, okay? He looks angry. So, signs of compensated shock. So these are just signs that our body is doing what it can to fight off whatever it is, to fight the good fight. You know, they're pissed off, they're agitated, they're anxious, restless, they feel like they're going to die, They have a weak or rapid pulse. Some might say thready. We'll talk about thready pulse when we get to circulation, but just know the pulse is very thin. So when you feel it, it feels very, very like a piece of thread. That's a thready pulse. Their skin, pale, cool, clammy. They're going to be a little pale. Probably have nausea, vomiting. Cap refill might be a little bit longer. Okay, they're going to get thirsty, and they're going to have that narrow pulse pressure to where that blood pressure is going to be like 120 over 110. When we start getting decompensate, that blood pressure drops below 90. Mental status starts to change. The breathing becomes more ataxic, more abnormal, more irregular. They become less pale, more mottled. And now they go from being pale to just ashen white or cyanotic blue. Pulses might go away. You might not feel a radial pulse. You might be able to only feel a carotid pulse. And then the eyes are no longer going to want to be able to dilate or constrict, and they're just going to start to dilate. And then because of all that, we're not going to pee. Not that urinary output is something we pay attention to as EMTs, but we definitely pay attention to that in long-term care. Like I said, look right here in the red. I said this before, I'm going to say it again. Blood pressure is the least measurable factor when dealing with changes of shock. When the blood pressure starts to drop, especially in kids, they are very, very close to death. So just know, blood pressures are great to know, but when it comes to somebody in shock, they're not a great indicator of how good or poorly they're doing, because typically the body is able to compensate and keep a relatively normal blood pressure until it can't. Okay, so like you might sit there and say, okay, this is tough. There are so many patients, so many different shocks. Which one should I care about? Like, when should I even think about this? Well, this is, I wouldn't say an all-inclusive, but this one gives you a pretty good little indicator. Let's say somebody was in a multiple car accidents and they have multiple fractures, rib fractures, femur fractures, leg fractures, clavicle fractures. Probably going to expect shock. If they got hit in the chest with a baseball bat really hard or in the abdomen, probably should suspect that. If they get stabbed, probably should suspect that. A spinal cord injury, severe infection, a really bad heart attack, or allergic reaction. These are the type of patients that if we get dispatched on any of these calls during our seeing styes up or running our mind of what it could be, we have to know, okay, this person is in a really bad car accident. I should probably be looking out for shock, and we better treat shock, especially as EMTs. There's not much we can do for that except for rapid transport, high flow oxygen, keep them warm in position of comfort. Blah, 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 blah. So basically this whole long slide is just saying that when we want to treat shock, we have to be able to identify it. And we treat shock by maintaining an airway, ensuring they have oxygen. If they need to be splinted, they're on a backboard. Don't let them drink or anything. And then we are always monitoring their oxygen and their breathing, always assessing their mental status. Mental status is one of the best indicators that we have on how well or poorly somebody is doing. That's the reason why when you guys watch a lot of these shows on Night Watch or Live Rescue or whatever it is, and you hear the paramedic say, hey, medic, can you keep talking to me? What's going on? And they keep asking them questions. They're always assessing that mental status, because one of the first things to go bad is alter mental status. So we always want to know as soon as they become so confused that they can no longer talk to us, it's a bad sign. Okay, if they're in shock and we are way too far away from a hospital and we can't get there fast enough, we might have to call for the paramedics. But the key thing here for this slide right here is if they are in shock and they are not stable, we must take our vitals every 5 minutes. Every 5 minutes, every 5 minutes, every 5 minutes for unstable patients. every 5 minutes. A full set of vitals every 5 minutes when they are unstable. For the last time, 5 minutes, vital signs on somebody that is unstable. That is so 100% a test question. All right, here we go, treating. So now we've talked about the different shocks. Now we're going to treat the different shocks. And guess what, EMTs? There's not much we can do, okay? Our main thing here as EMTs is just identifying it. There's not much we can do as EMTs to fix it. Okay, so cardiogenic shock. These patients generally lower normal blood pressure. When I say low blood pressure, I'm saying instead of being like 160 over 90, their blood pressure might be 110 over 80. So like a little bit lower systolics. Their pulse might be weak or irregular. They might have some cyanosis. Probably going to have some lung pulmonary or pedal edema. Maybe they'll be a little anxious. We do not want to give these patients nitroglycerin. Nitroglycerin is only for heart attacks or chest pain when the blood pressure is above 100. So do not give these homeboys nitroglycerin. You will probably kill them. This says place the patient in a position that eases them. They will be able to tell you what position they are able to breathe best in. Ask them and then keep them in that position. Don't tell them how to breathe. They're going to subconsciously find the best position that they can breathe. Just help them breathe that way. Put them on high flow oxygen, assist ventilations if needed, keep them warm, and drive quickly. Cardiac tamponade. This is part of that obstructive shock. This is where they're going to have the Beck's triad. Remember I talked about Beck's triad? The low blood pressure, the muffled heart tones. The muffled heart tones, the low blood pressure, and the JVD, the jugular vein distension. These are the three things that make up the Beck's triad. Now, I just forgot it right there really quick. So that just shows you how easy it is to forget that stuff. Remember that. Beck's triad, JVD, hypotension, narrow pulse pressure, muffled heart tones, JVD. Those are the three things we want to look for with the Beck's triad. Drive these people fast, get them on oxygen. They need surgery. All right, tension pneumothorax. We talked about this. This is where the lungs get compressed, filled with air, and it causes the amount of pressure to be too good on the heart, and it causes the heart to not beat effectively. These people need needle decompression. They need literally a needle put into their pleural cavity to have that air escape. Don't delay transport. If you can get an EMT or a paramedic there quickly to help do that needle decompression, like if you have an AAOS paramedic that's like on a supervisor buggy and they can get there, call them. Or just drive as fast as you can to the hospital. These people will have absent lung sounds on one side, shortness of breath. These people absolutely need to get surgical care. Septic shock, like I said, this is one of those things that we are going to see a lot of as EMTs. High flow oxygen, keep them warm, transport them to the closest hospital. And what we do this thing called, it says notify sepsis team available. We actually say a thing when we call them in. When we call this in, we will say this is going to be a code sepsis. And that way they can get their septic protocol ready in the ER room, because it's so vast and so important that if we know that this patient is septic and we can tell the ER en route, it is that much more advantageous for the patient and for you. So septic shock, massive infection, it gets over the whole body. These patients will need high flow oxygen, keep them warm, rapid transport. Neurogenic shock, which again, this is where the spinal cord gets injured. Spinal cord is no longer able to get the impulses down to the body, and the body's no longer able to send impulses back up. So this is where the neurogenic shock comes in. These patients need rapid transport, keep them warm, provide airway, ventilation, transport properly, all the same stuff. Here's our epi. This is for anaphylaxis. There we go with an EpiPen. If the patient has it and they are in anaphylaxis, give the EpiPen. As you see right there, you rip off that blue thing up top, and then you just shove the orange thing into the thighs. Hold it on there for about 5 to 10 seconds. And that's epi. That's an EpiPen. You will see a drastic and pretty quick change, hopefully, once this is administered. The dose of epinephrine, if you can look up there, it says 0.3 milligrams. So 0.3 milligrams of epinephrine going into the body, intramuscular. So it's going to go into the muscles. Psychogenic shock, this is, like I said, the bad news bears. They typically just wake up on themselves. Make sure they're not injured. Make sure nothing else is going on with them. This is probably going to be a very common one that we run. There's nothing wrong with them. Hypovolemic shock, we must be able to stop all the bleeds. Keep those homeboys warm. Look for any type of internal bleeding, airway, breathing, circulation, and rapid transport. So pretty much you've seen for all of our shocks, all of our treatment is rapid transport, high flow oxygen, airway support, keep them warm. And for our last one, we got our old people. Old people take a lot of medications. Old people might not be able to compensate or show signs and symptoms as quickly as a regular person. So just know that old people, they could have internal bleeding. And typically one of the first signs of internal bleeding is an increased heart rate. But because those old people are taking certain types of medication, their heart might not be able to beat faster because it's being blocked. And that could mask the signs or symptoms of an internal bleed. Guys, just to wrap up, remember shock, inadequate tissue perfusion, how we treat it, doesn't really matter what it is. High flow oxygen, rapid transport, keep them warm. Airway management if it needs it. Alright guys, that pretty much wraps up shock. It's really important that you guys understand this. Maybe make sure that you guys can differentiate the difference between hypovolemic, distributive, and cardiogenic shock. If you guys have any questions about this, feel free to hit me up in class. Peace.